Okay, so they're still working getting the next patient ready, so we're going to go on to one more lecture. So we'll be done with the tricuspid session by the time we get to the mitral. Okay, so that's the good news. All right, so Anita Asgar is from the Montreal Heart Institute is going to come up, and Anita is also one of the leaders in the tricuspid space as well as the mitral space, and she's going to talk to us about the green, yellow, and red zone patient as it applies to tricuspid TEER. Thanks, Anita.
Thank you. So Gilbert asked me to talk about the red, yellow, and the green. Not my favorite way of looking at this, so I decided to change the title to Selecting Patients for Tricuspid TEER. What are the right questions to ask? Because I think at the end of the day, it comes down to asking the right questions to understand who's a good candidate. So to start, it's important to remember what the goals of tricuspid TEER are. And this may seem a little basic, but it is important to understand. What we're trying to do is restore leaflet coaptation and thereby reduce tricuspid regurgitation. And the keys to success when we're trying to plan our procedure is to really understand leaflet anatomy, understand the mechanism of TEER, and using that information, develop a strategy to restore leaflet coaptation. So is it really as simple as red, yellow, and green? I don't think so. I think it's really going to be more of a multicolored approach, but really trying to understand the anatomical challenge and therefore asking the right questions and making decisions based on those answers. So these are the things I think are probably the most important when we're trying to select patients for TEER. One, what is the mechanism of the tricuspid regurgitation? Two, what is the quality of the TEE imaging? And Rebecca Hahn is going to talk to us about this, but obviously we can't clip what we can't see. How do you describe the regurgitant jet? Because that will help you to understand, what type of procedure you're going to be looking at if you can do it. How many leaflets are you seeing on the transgastric view? So do you understand the anatomy? And then what are the leaflet lengths? Probably the less important of the five. So in terms of the mechanism of tricuspid regurgitation, it can be very diverse as well. We talked about mitral valve disease, but tricuspid is no less complicated. Something we see less of, but certainly does exist, degenerative disease with leaflet prolapse, leaflet flail or chordal rupture, annular dilatation from RV enlargement. What we're seeing by and large is actually more annular dilatation from atrial enlargement with atrial fibrillation, septal leaflet tethering from RV enlargement, and then another important subgroup of patients are these patients with devices, so lead interaction. It's important for us to understand where is the lead and is it playing a role in the TEER. What is the quality of the imaging? So I'm not going to go into exhaustive detail, but we do have to see the leaflets if we want to actually grab them. Do we have a good transgastric or do we have a good MPR? Are there any problematic shadowing that's going to impede us from seeing? And is the heart horizontal? If it is, it's not an absolute contraindication, but we do need to be able to see the septal leaflet. How do we describe the regurgitant jet? How many leaflets? We're going to talk about these. Is the regurgitant jet central or eccentric? Is it wide or is it focal? And where is the location? And so this is just an example of the leaflet morphology. As we know now, the tricuspid valve does not just have 3 leaflets, that is the type 1, but there can be multiple configurations. And these are important, not just for the number of leaflets, but to really understand the different coaptation planes. Remember, the goal of the procedure is to restore coaptation. If you don't respect the planes, you may restore coaptation in one area only to open a coaptation plane in another area. And hence the distortion of those coaptation planes can actually lead to new regurgitation after you've put your device in. And so this is just an example. I've sort of drawn in my little blue clips here, but depending on what your anatomy would be, you have to adjust your strategy to try to attack those particular anatomies. And so then what are the leaflet lengths? I mean, this is really going to impact the choice of clip you're going to use. I speak about the clip. This is what's actually approved commercially in Canada. We don't have access to Pascal, but we do have commercial approval, so we can treat these patients commercially. And so there are 4 clip sizes like we've seen with mitral, and so making a choice based on what's appropriate for each of the clips. So what type of anatomy is less suitable? So obviously, if you have severe leaflet tethering, if you have carcinoid, if you have endocarditis, these would be a flat no for a TEER procedure. What is the quality of imaging? So who's less suitable? Obviously, it's poor. Now, we are seeing that ICE, or three-dimensional intracardiac echo, has a huge role probably to play in tricuspid TEER, but we do need to have some sort of imaging, be it ICE or TEE. The regurgitant jet, the very large jets, are probably less likely to be suitable candidates for T-TEER. There's probably no leaflet limit in terms of exclusions for T-TEER, but we do need to understand and respect those coaptation planes. Oh, I just lost my slides. Okay. Oh, I lost them again. I'm going to read them from over there. And then what are the leaflet lengths? So obviously very, very short restricted leaflets are going to be difficult to clip. So I'm going to try to put this sort of questions into a case for you and see if that can help you understand how we might approach a case depending on the types of questions. So we have an 84-year-old male with severe symptomatic TR, multiple admissions for right-sided heart failure. He's on maximal medical therapy with diuretics. He also has chronic renal impairment. He also has a previous history of a permanent pacemaker implanted 20 years ago. So what questions do we ask, and is this patient a T-TEER candidate? So these are our 5 questions. This is the case. So this is our RV inflow of an X-plane on the left, with and without color. The color's on the right. So you can see the tricuspid regurgitation. You do see the lead here and here. Obviously, these aren't sufficient views, and I'm not showing you the entire study, but just to give you a sense. And this is the transgastric. And so the way that the image is aligned, this is the septal leaflet here, anterior here, and posterior in the back. And you can see this lead is right here in the posterior septal, almost in the commissure, but certainly more posterior. Not sure why that won't play. You can see the jet there. So we felt, I didn't show you all the images, but that the mechanism of tricuspid regurgitation here was actually not the pacemaker lead, but rather annular dilatation with a central jet of tricuspid regurgitation. We felt the quality of the imaging was good. There was no significant shadowing. We could see the leaflets with the pacemaker, and the transgastric imaging was good. How did we describe the regurgitant jet? It was central. It didn't appear to be associated with the pacemaker, which was relatively posterior. And how many leaflets we felt? We saw 3. Most importantly, though, we didn't feel we saw impingement of the septal leaflet by the pacemaker, which could potentially be a contraindication, and we felt the leaflets were long. So now that we've decided that he's potentially a T-TEER candidate, how are we going to choose to restore coaptation? Which clip are we going to use? Where are we going to start? And how many did we think we were going to need? So this is sort of taking these questions and sort of translating them into your procedural strategy. So in order to restore coaptation without distorting the anatomy, we have to be perpendicular to the line of coaptation that we're trying to target. And so our decision was to start anteroseptal, practically commissural, and then mid, and potentially central, depending on the result. Obviously, when we're clipping, we need to clip the most anterior first because the subsequent shadowing makes it difficult to go back. And so this is our first clip. We placed our first clip anteroseptal commissural. You can see it's not really commissural, but close to the commissure. And you can see we brought the septal and the lateral wall in with that first clip, but we still have significant TR. So what do we do now? Well, we decided we're probably going to put at least 2. So this is our second clip. We've decided to go right on top of that one. This is our second one right here. Anteroseptal mid. This is another XTW, so the long and wide clip. We still see some TR here. So what would we do now? Are we done? Do we add another clip? If we get to moderate, patients seem to do well, but can we do a little bit better than that? So we decided to add another one. So we placed a third clip. This is pretty much anteroseptal central. And you can see now with our third clip, we've practically eliminated the TR. You might have to take my word for it if it doesn't want to play. There you go. So there's still a little bit of TR, but certainly much better than what we started with. And this is our final gradient. So 3 XTW clips and a mean gradient of 1. So in conclusion, I would say that patient selection for tricuspid TEER really depends on an understanding of the mechanism, the leaflet anatomy, and of course incorporating the quality of your echocardiographic imaging, and to really think about how you can restore leaflet coaptation without distorting the anatomy or opening new planes of coaptation between particularly the anterior and posterior leaflets. The goal is to restore and not to distort. And then basically choosing your clips based on your leaflet lengths at the target grasping area, but also look at how much leaflet is available. So not as simple as green, yellow, and red, but asking the right questions I think will get you to the right answers and help you to decide how to do a good procedure for your patients. Thank you.